Good evening, one and all. I'm Dr. Karthik Vijayakumar, your endocrinology faculty at Doc Tutorials. So, today we are starting or kicking off the proceedings of a lecture series rather not a lecture series per se, a practically oriented live sessions, which is in accordance with the Doc Tutorials internal medicine residency program. And we'll be conducting weekly practical sessions on how to approach certain conditions, medical conditions that will be helpful for you, certain guidelines, certain new drugs, all those things that will enrich your clinical armamentarium and that will make you a better clinician. So, as you know, our residency program is aimed not for you to clear the entrance, but to help you sharpen the skills as a clinician and to get you a clear idea regarding the approach to many clinical conditions across the specialties. So today, as part of the endocrinology discussion, I've chosen the topic approach to hypoglycemia in a non-diabetic patient. So you must have come across so many patients who had hypoglycemia predominantly from diabetes point of view, mainly iatrogenic, the drug related either insulin or oral medication. But many a time, a patient would come to your OPD or would get admitted with certain non-specific symptoms like fatigue, palpitation, history of loss of consciousness, and you may suspect hypoglycemia as the causative factor for that. And when I was a medicine resident, this was one of the area where I had absolutely no idea. I would send off some random serum insulin C peptide, and I really had no idea how to interpret, when to send, and how to proceed with a case of hypoglycemia. So I've specifically chosen this topic because this is not very well covered, or the practical approach is not well covered in the textbooks or in the guidelines. So, in this probably 45 minutes to 1 hour session, I would like to give a clear insight regarding the approach to a suspected hypoglycemic disorder, not the hypoglycemia in a diabetic patient, the suspected hypoglycemic disorder. So I hope the students who have logged in to the live session are able to see the video and audio clearly. And I would request the students, whenever their doubts crop up, please type that in the chat box. And at regular intervals, I'll be addressing the questions which have been posted in the chat box also. So I think we can start the session right away. So as a clinician, these are some of the questions that you need to answer when a patient presents with the symptoms that could suggest hypoglycemia or low blood glucose, when to exactly suspect hypoglycemia, and in those with suspected hypoglycemia, how to go about the evaluation right from the history taking to the examination, and finally biochemistry, and if needed, the imaging investigations as well. Once you uh, investigate the patient stepwise, that is fruitful only if you know what are you searching for. So you should know what are the conditions that can present as a hypoglycemic disorder, and you must have heard about the 72-hour fast test, which is considered the gold standard in the evaluation of hypoglycemic disorder, and that is sometimes a very cumbersome and risky procedure to do. So you should know in and out everything about 72-hour fast test. What are the indications, when to do, when not to do, what is the protocol, everything I'll be covering in detail. And finally, the most of the cases that you see in adult patients with hypoglycemic disorders are in fact insulin dependent hypoglycemia. So we'll be covering those aspects also in detail. Right. So I will start the discussion today with a case study. Okay, with a case study. So this is about a 37-year-old man, so a middle-aged man. He presented with recurrent episodes of giddiness, fatigue, increased sweating, and loss of consciousness with a very long duration of 7 years. So from the symptom onset itself, it is giving some clue that it could be a potential hypoglycemic disorder. Okay, all the giddiness, fatigue, sweating, everything that you associate with hypoglycemia, but you are still not sure. Many a time you see such patients with such long duration of symptoms. Often you neglect that because hypoglycemic disorder cannot exist for such long time without a diagnosis, but that is not actually the case. Okay, so these symptoms were not associated with abnormal movement of limbs, tongue bite, or urinary incontinence. So as evidenced in the history taking, I was meaning to mention seizure. So even though there were episodes of loss of consciousness, there was no reported seizure. But these loss of consciousness, episodic ones, the patient sought medical attention and was diagnosed as a seizure disorder and was started on anti-epileptics. So this is such a common occurrence where the treatable metabolic causes of seizures or loss of consciousness like a hypoglycemia, hypocalcemia, hypomagnesemia, such things would be erroneously treated as a seizure disorder with anti-epileptics, and the patient would still continue to have seizures despite on very high doses of anti-epileptics if you fail to identify the culprit metabolic cause. Right. So this patient, upon presentation to us, still has been having around 2 such episodes per week with continuing visits to the hospital. And at the hospital, he used to get IV dextrose, and there was prompt relief of symptoms with IV dextrose. Very important. So in this context, I would like to introduce a term which is called as the Whipple's triad. Whipple's triad, and most of you would be already knowing this Whipple's triad. That means that the patient should present with symptoms suggestive of low blood glucose. There should be a documentation of low blood glucose, the threshold that we will learn later on. And finally, there should be prompt resolution of symptoms with administration of glucose. So all these three factors should be satisfied to say that the Whipple's triad is positive. So there should be symptoms of low glucose, there should be documented low blood glucose, and finally the symptoms should resolve by administration of glucose. This is extremely important. Why? Because many a time you will get referrals, or the patients may tell you that, sir, I've experiencing fatigue and palpitations for so long, and I went to the casualty or emergency room one time, and when they checked the blood glucose, it was 60 milligrams per deciliter. So you may think that, yeah, this patient is suffering from a hypoglycemic disorder, but you will have to identify the fallacy around that fact, because most often in emergency rooms the blood glucose is measured with the help of glucometers. At extremes of blood glucose, many of the glucometers show high inaccuracies. So a blood glucose of 70 or 75, which should otherwise be considered as normal, may erroneously be reported as 50 or 60. That is an inherent flaw with many of the glucometers. So you just cannot rely on a single glucometer reading alone, and you cannot label the patient as having a hypoglycemic disorder just based on such findings. And one more point I would like to highlight is when I mentioned Whipple's triad, there was the third point was prompt resolution with glucose or dextrose. That is very important. If the symptoms were due to hypoglycemia, unless the patient had a prolonged hypoglycemia with neuroglycopenic symptoms, he should experience prompt reversal with administration of glucose. Many other conditions can mimic the hypoglycemic disorder. They may have some effect due from administration of glucose, but not complete reversal. So if such dramatic relief is not obtained with administration of glucose, you should think slightly away from hypoglycemic disorder. That is another practical point. Okay, right. So in order to avoid these symptoms, this man used to take frequent feeds because he was attributing everything to low blood glucose, and in order to avoid that, he takes frequent feeds. And most episodes usually in early occurs in early morning hours when there is a delay in intake of feeds. So when you suspect a hypoglycemic disorder, you want to get from the history whether the symptoms are predominantly fasting or postprandial. Fasting or postprandial. Why is it important? Because there are certain conditions which present with predominant fasting hypoglycemia, like your insulinoma. So insulinoma where there is an autonomous production of insulin from a pancreatic neuroendocrine tumor, they would have predominantly fasting hypoglycemia, but postprandial can also occur. Whereas certain other entities like reactive hypoglycemia or post-bariatric surgery hypoglycemia, Hirata syndrome, they most often occur in the postprandial period. So identifying the temporal sequence of events, when does the patient develop most of the symptoms, is also important regarding the causative etiology. And looking at the history, there was no history of diabetes, because you should always rule out that. You have to rule out any iatrogenic cause for hypoglycemia. No history of intake of any drugs that can cause hypoglycemia. Which are the drugs that result in hypoglycemia? We will learn in due course of time. No history of liver, renal disease, or cardiac disease. Why? Because in a sick patient, organ failures, be it liver, renal, or cardiac failure, can result in low blood glucose. So it is very important to rule out these end organ dysfunctions or major organ dysfunctions in a patient with hypoglycemia. Now tell me, why is the history of abdominal pain, vomiting, fatigue, hyperpigmentation, low BP recordings, hyponatremia, why are all these factors important in a patient with hypoglycemia? So as you might have rightly guessed, this could suggest the possibility of adrenal insufficiency. To be specific, primary adrenal insufficiency. Why? Because the patient also has hyperpigmentation. Okay, so adrenal insufficiency is one of the treatable causes for hypoglycemia, recurrent hypoglycemia. Both primary and secondary adrenal insufficiency can result in that. So this is again one point that you should ask in the history, and you should rule out during the biochemical evaluation. So ruling out adrenal insufficiency and other organ failures is also very important while evaluating a patient with hypoglycemic disorder. And 3 years back, he gave the history that his random blood glucose was low, and it was there at the development of symptoms. And the lowest recorded GRBS was as low as 80 milligram per deciliter. And there was prompt resolution with dextrose. So it is clear that the Whipple's triad is satisfied from his history itself. So when Whipple's triad is positive, there is a very high probability of a organic hypoglycemic disorder. Okay, so once Whipple's triad is satisfied, you think of a pathology which is causing the hypoglycemia. Okay, so at this background, with the patient, 37-year-old male with recurrent episodes of hypoglycemia, often severe hypoglycemia resulting in loss of consciousness, and as low as 18 milligram per deciliter of glucose has been recorded with prompt resolution with glucose administration. So this is the history that we have so far. Now look at the basic questions that you need to be answered, and this is extremely important for your viva, for your general clinical knowledge, and few points may come as a question in your entrance examination, also for super specialty examination. So first and foremost thing that you should answer is whether the symptoms the patient is telling is due to hypoglycemia or not. Okay, so let's see what happens when a patient's blood glucose is coming down. And MCQ point also lies there. The first thing that is going to happen when the blood glucose touches around 80 milligram per deciliter is the suppression of insulin release. So you can tell that this is the first line of defense against hypoglycemia. So at this time, the patient will not have any significant symptoms, around 80 milligram per deciliter. So once the blood glucose crosses below 70, there occurs a surge of counter-regulatory hormones. So which are the counter-regulatory hormones? You have the catecholamines, you have the glucagon. So glucagon should be the primary counter-regulatory hormone. Okay, glucagon is the primary counter-regulatory hormone against hypoglycemia. Then you have cortisol, GH, etc. Okay, so glucagon, catecholamines, cortisol, growth hormone, everything will be released, and especially these catecholamines will cause the autonomic symptoms. Okay, autonomic symptoms means sympathetic system activation, sympathetic nervous system activation, both adrenergic and cholinergic. So both sympathetic adrenergic and cholinergic activity will be increased. Thereby, the patient will start experiencing the autonomic symptoms of hypoglycemia. And less than 50 to 55 milligram per deciliter, the patient will have neuroglycopenic symptoms. The brain will start getting deprived of glucose and the patient will have neurological symptoms. So this is the sequence of events when the patient is coursing through low blood glucose levels. And let's see what are the symptoms. So these are the autonomic symptoms or the neurogenic symptoms. So these are also called as the warning signs of hypoglycemia. The patient will have sweating, will have palpitation, hunger, anxiety, etc. And of these, sweating is cholinergic, hunger is also cholinergic. All the remaining are adrenergic. Okay, sweating and hunger is mediated by sympathetic cholinergic fibers, whereas all the others, the palpitation, the pallor, anxiety are all sympathetic adrenergic mediated symptoms. And once the blood glucose is less than 50 milligram per deciliter, 50 milligram per deciliter, there will be neuroglycopenic symptoms. The symptoms that indicate that the brain is getting deprived of glucose. The patient will have confusion, disorientation, loss of consciousness, seizures, coma, etc. So unless there is some significant underlying issue, the patient will always experience autonomic symptoms first, then only the neuroglycopenic symptoms will come. But there are certain situations where the autonomic symptoms are absent and the patient would straight away present with neuroglycopenic symptoms. We call them as hypoglycemia unawareness. Hypoglycemia unawareness. This occurs in patients who are getting repeated episodes of hypoglycemia, so frequently happening episodes of severe hypoglycemia, and this will lead to the blunting of autonomic response or the downregulation of the sympathetic response, leading on to the absence of autonomic symptoms. So when the patient is developing hypoglycemia, there will not be any warning sign, and the first sign would be the patient readily getting unconscious or developing neuroglycopenia. This is called as hypoglycemia unawareness or Cryer syndrome. Cryer syndrome, based on the scientist who first described this entity, who is the Philip M. Cryer. Okay. So you'll always have to look at the presence of these symptoms while evaluating the patient. And of these, which is more specific for hypoglycemia, it should be neuroglycopenic symptoms. So if a patient reports loss of consciousness or seizures during such episodes, then the positive predictive value or the likelihood of that episode to be due to hypoglycemia is very high. Whereas if the patient just reports palpitation, of fatigue and irritability, then it could be due to umpteen number of causes that is not specific for hypoglycemia. So from history, you should specifically ask for the presence of any neuroglycopenic symptoms. Okay, now how are you going to define hypoglycemia in a patient without diabetes and hypoglycemia in a patient with diabetes? So is there any such technical difference? Actually, there is. Although it is not endorsed by professional guidelines, what we clinically use is that in a normal patient, that is without any glucose metabolism disorder like diabetes, less than 55 is what you consider as significant hypoglycemia. Significant hypoglycemia. Of course, the normal blood glucose in an individual, you can say in the fasting state, is around 70 to 100 milligram per deciliter. So logically, you may think that anything less than 70 would be abnormal. But in many normal individuals during fasting periods, the blood glucose would fall below 70, like 65, 60, like that. But you don't usually call them as hypoglycemia. So less than 55 in a patient without diabetes is considered as significant hypoglycemia, whereas In a diabetic patient, you consider less than 70 as the cutoff for hypoglycemia. So less than 70 is the cutoff for hypoglycemia in a diabetic patient. And you have 3 levels of hypoglycemia. Level 1, 2, and 3 based on the International Hypoglycemia Study Group classification. Level 1 means the blood glucose is between 54 to 70 milligram per deciliter. Level 2 means blood glucose is less than 55. That means 54 or less milligram per deciliter. And level 3 means the patient, whatever be the blood glucose, if the patient requires third-party assistance. Third-party assistance, you call it as level 3 hypoglycemia. So this is another important relevant question. So any patient with level 3 hypoglycemia, especially in diabetes, you should take that as very, very significant irrespective of the blood glucose level. So the blood glucose that you check at that time of unconsciousness may be 60 milligram per deciliter, which is not confirming with the diagnosis of significant hypoglycemia in a non-diabetic patient. But if the patient had neuroglycopenic symptoms that warrants the assistance of another person, then you should consider it as significant and you should evaluate for hypoglycemic disorder. So that is a slight difference in the cutoff in patients without diabetes and with diabetes. Okay. So what is Whipple's triad? We have already seen there should be low blood glucose symptoms, that hypoglycemic symptoms, and it should be accompanied by low blood glucose value and the symptom relief with glucose. So if you are able to make sure that the Whipple's triad is satisfied by taking the history of the patient, then there is a high likelihood that the patient is suffering from a hypoglycemic disorder. Okay, now how do you classify causes of hypoglycemia? So when you get a call from the nursing officer that this patient has developed hypoglycemia and the blood glucose is 50 milligram per deciliter, the first thing that you should ask that individual is that whether the patient is sick or the patient is a seemingly well individual. Seemingly well individual. This is extremely, extremely important because where do you expect the sick patient to be? In the ICUs or in the high care units of the ward. And these patients are more likely to have renal failure, sepsis, liver failure, cardiac issues, etc. So all these patients, and the patients will be on multiple drugs. So when a sick patient is developing hypoglycemia, you have to think of an entirely different spectrum of diseases like the target organ failures, acute infection, decompensated adrenal crisis, use of multiple drugs. All these should be taken into account. Whereas a patient comes to your OPD with history suggestive of multiple hypoglycemic episodes, and if the patient is admitted for some other reason in your hospital, but now he's reporting hypoglycemic symptom and he's a seemingly well individual, then you have another set of causes. Okay, so now in this session, I'm dealing mostly with hypoglycemia in apparently normal person. Apparently normal person. So of course, in this discussion, I am excluding patients with diabetes. Okay, so hypoglycemia in apparently normal person, how are we dividing? We are dividing them into insulin dependent causes and insulin independent causes. So insulin dependent means the cause for hypoglycemia is insulin acting on its receptor. We have learned that in a normal individual with intact response to hypoglycemia, the insulin release or secretion should cease to zero level at glucose level of around 80 milligram per deciliter. So if the blood glucose is 50 milligram per deciliter and the insulin levels are still high, then you can be sure that the patient is having insulin dependent blood hypoglycemia. Okay, so what are the causes that comes under insulin dependent causes? Of course, the insulinoma, drug induced. You have the insulin itself. Then you have the secretagogues, insulin secretagogues like sulfonylureas, meglitinin analogs, etc. Then you have reactive hypoglycemia, you have Hirata syndrome, etc. Okay, Hirata syndrome. So many causes that we will deal one by one. Then you have insulin independent cause. Okay, insulin independent cause. There are a different set of cause in childhood and in an adult population. Suppose a patient with a large mesenchymal tumor in the abdomen or in the thigh now presenting with insulin independent hypoglycemia. What would be the diagnosis? Anyone? A patient with a large abdominal tumor presenting with insulin independent hypoglycemia. Can anyone guess what could be the answer? The answer would be IGF-2 related. IGF-2 related. This is nothing but paraneoplastic hypoglycemia. Paraneoplastic hypoglycemia. And I would mention one eponymous name for this condition, which was previously asked in one of the entrance examination. Dodge-Potter syndrome. So paraneoplastic hypoglycemia due to a mesenchymal tumor, especially in the mediastinum, is what you call as Dodge-Potter syndrome. Okay. Then you have the other set of causes like the adrenal insufficiency, hypopituitarism, then whole inherited metabolic disorders, like the fatty acid oxidation defect, the disorders of gluconeogenesis, disorders of glycogenolysis. So everything can result in insulin independent causes, but these are of interest mainly in the pediatric population, and these things hardly present to a physician for evaluation. Okay. So this is in broad regarding the causes of hypoglycemia. We have divided it into insulin dependent and insulin independent. Now, a few drugs that can cause hypoglycemia. So if you look at the literature and some of the textbooks, you can see a very large list of drugs that can potentially result in hypoglycemia, and that may include very commonly used drugs like the ACE inhibitors, the ARBs, the beta blockers. But you just cannot say that just because the patient is taking an ACE inhibitor and it is listed in a textbook that can cause hypoglycemia, you just cannot attribute ACE inhibitor ARB as a cause for hypoglycemia, because the use is so rampant and it is highly difficult to single out a cause. So if you have ruled out every other possible cause and the patient has significant relief of hypoglycemic symptoms after the withdrawal of the drug, then you can potentially say that this drug could have been the cause for hypoglycemia. But establishing the causal association with certain drugs is very difficult. But there are certain drugs like insulin, OHA that are strongly associated with hypoglycemia, which could be given as part of treatment, or it could be the surreptitious use of the patient that could result in hypoglycemia. Then certain other drugs like the quinolones, especially the gatifloxacin, levofloxacin, etc. Then anti-malarials, the quinidine, artesunate. Then administration of glucagon in a patient who has been fasting, that can also result in paradoxical uh, hypoglycemia. There are so many other drugs being mentioned like the sulfonamides, the losartan, the irbesartan, everything have been mentioned. But unless you find any drug in these groups, you just cannot straight away label that this drug is the causative factor for hypoglycemia. So just for your exam point of view also, sometimes you may get the secondary causes for hypoglycemia. There you should know at least 4 or 5 drugs apart from the anti-diabetic medications that could result in hypoglycemia. Okay. Now there is an entity called reactive hypoglycemia. You must have heard it so many times. So what do you mean by reactive hypoglycemia? And this is mainly a postprandial event. Postprandial event. And the basic cause for reactive hypoglycemia is the exaggerated insulin response following a meal. So exaggerated insulin response following a meal is the most common cause for reactive hypoglycemia. So in which situations you think of reactive hypoglycemia? One, in patients with pre-diabetes and obese patients, and those patients taking high glycemic index foods. Then post-bariatric surgery patients. So why does the pre-diabetic obese patients and high glycemic index intake patients develop this reactive hypoglycemia? You know, in pre-diabetes, the first abnormality that usually occur is the loss of first phase insulin secretion. Loss of first phase insulin secretion. So what happens whenever the patient takes food, especially the simple carbohydrate rich high glycemic index food, there would be a sharp spike of glucose due to the lack of first phase insulin production. So later on, these patients would have an immediate hyperglycemia due to lack of first phase insulin secretion. But later on, the body would try to compensate by producing additional amount of insulin, followed by additional insulin production. And when these individuals are taking high glycemic index foods, what will happen? There will be a sharp spike or rise in blood glucose followed by a sudden fall. So when the blood glucose is high, there is not enough insulin to counteract that. When the blood glucose is falling down, then your body will be producing excessive amount of insulin, so that the patient would develop late postprandial hypoglycemia. Late postprandial hypoglycemia at around 3 to 5 hours. So 3 to 5 hours following a meal, the patient develops hypoglycemia, and this pattern is repeated and repeated time and again whenever the patient takes low glycemic index foods. So this history is very important. Okay. And in such patients, you specifically look at the fasting blood glucose level, the HbA1c, and see whether it belongs to the pre-diabetes category. And in such patients, instead of doing a 72-hour fast test, what you will be more interested upon would be doing a mixed meal test. Mixed meal test means you would give the high glycemic index food or the usual meal that result in hypoglycemia in a patient, and you check for blood glucose every 30 minutes and see whether the patient develops hypoglycemia at 3 to 5 hours. And in the sample that shows low blood glucose, you check for insulin to confirm the insulin dependent hypoglycemia. That is how you diagnose reactive hypoglycemia. And how do you manage this patients? You ask the patient to reduce the weight. You some drugs may be useful, and you will ask the patient to take low glycemic index food. And one drug that could be useful in such condition is acarbose. Acarbose, or the alpha glucosidase inhibitor. Why? The sharp rise in blood glucose is the one that is triggering the late insulin release. So but any cost, you will have to avoid that sharp rise in glucose. One method is to give a low glycemic index complex carbohydrate with protein rich meal. And second, to give a drug that will slow down the carbohydrate absorption so that the glucose peak is delayed and blunted. So these are the methods in patients who are suspected to have reactive hypoglycemia. And even without doing a mixed meal test, you can try these in your OPD basis by adjusting the meal timings, by adjusting the meal content, and by addition of certain drugs. Okay, I hope the reactive hypoglycemia is clear for you. So anyone has any need for clarification from whatever we have learned so far? Anyone? So any doubts, please feel free to comment on the chat box so that we can clear the doubts in between itself. So if there are no doubts so far, we can proceed on to the next section of our discussion. So we had discussed about a patient, a 37-year-old male with recurrent episodes of significant hypoglycemia with neuroglycopenic symptoms and with positive Whipple's triad. Okay, and there is no evidence of any secondary causes like organ failures, adrenal insufficiency, etc. Okay, so general examination, of course, in any patient, you will have to look at the vital signs. Vital signs are all within normal. The routine general examination is normal. Now, what is the importance of acanthosis nigricans in a patient with diabetes? Okay, so acanthosis nigricans, why does it occur? It is due to the increased IGF-1 action on its receptor, IGF-1 receptor. So a patient develops acanthosis nigricans due to IGF-1 action on IGF-1 receptor. But when insulin levels are very high, this insulin can bind to the IGF-1 receptor. So that is why in obese patients with hyperinsulinemia, you see acanthosis nigricans, and it is considered as one of the main markers of uh, insulin resistance. So acanthosis nigricans in a patient with hypoglycemia signifies the possibility of hyperinsulinemia. So it gives you a clue that you are dealing with a hyperinsulinemic disorder. Okay. And again, multiple skin tags are also due to the growth proliferatory action of insulin on the IGF-1 receptor. Now, can anyone say what is the link between cholangiomas, angiofibromas in a patient with hypoglycemic disorder? Anyone? Hypoglycemic disorder in a patient, and on examination you find small bumpy swellings on the skin, on the abdomen, on the face, and around the vermilion border of the lip, and on the nasolabial folds you are identifying small papular lesions which identified as angiofibroma. So this could be a case of MEN1 syndrome, because cholangiomas and angiofibromas are seen in MEN1 syndrome, and MEN1 syndrome could well have insulinoma as one of the pancreatic neuroendocrine tumor, which could be the cause for this hyperinsulinemic hypoglycemia. So these things you should take special account while examining the patient. Okay. And system examination, of course, the cardiovascular, respiratory, abdominal, and nervous system examination all within normal limits. So in abdomen, you should look for large masses in the abdomen, which could be the retroperitoneal sarcomas that can oversecrete the IGF-2 to result in paraneoplastic hypoglycemia. Okay, but this patient was having hypoglycemic disorder of very long duration, so it is unlikely to be caused by a paraneoplastic disorder. Right. So importance of examination in a patient with hypoglycemia. One, signs of insulin resistance, weight gain, this could suggest hyperinsulinemia. Then you should look for the stigmata of MEN syndrome, especially MEN1 syndrome. And also you should look for signs of adrenal insufficiency, like a palmar hyperpigmentation, mucosal hyperpigmentation, postural hypotension, etc. So all these things you should look in a patient with a probable hypoglycemic disorder. Looking at the investigations, I would be interested in looking at the sodium and potassium of the patient to see if there is any hyponatremia, hyperkalemia, which could make my life easy by diagnosing an adrenal insufficiency as the cause for hypoglycemia, but it is not the case. the HbA1c is also 4%. When the HbA1c is 4%, you can very well say that his ambient blood glucose levels is on the lower side, and in fact, he's likely suffering from a persistent hypoglycemic disorder. So if the HbA1c was 6.3%, we could be thinking of reactive hypoglycemia, not in this patient who has been having hypoglycemia for 7 years, but in a patients with recent onset of hypoglycemia, especially in the postprandial period, and the A1C is in the pre-diabetic range, then you should entertain the possibility of reactive hypoglycemia. But here, the A1C level, A1C level is very low, suggests persistent hypoglycemia. I think I've got one question: how organ failure can cause hypoglycemia? So, in fact, both renal failure, liver failure can cause hypoglycemia. Liver is one of the major sources for the gluconeogenesis and glycogenolysis. The glycogen stores are depleted as early as 8 hours of fast. So, gluconeogenesis is the major source for the counter-regulatory response. The glucagon can act and increase the blood glucose level only if there is sufficient glycogen there to be converted to glucose, or the liver is properly functioning for taking up amino acids, fatty acids to be converted to glucose. So if liver is not functioning, that itself is a cause for hypoglycemia. That usually don't occur in compensated forms of cirrhosis, but in decompensated states, like the patient is having severe hepatic encephalopathy and severe hyperbilirubinemia, or as bacterial peritonitis. Such situations, the patient can land up in hypoglycemia. And with regards to the renal failure, one thing is that the clearance of insulin will be delayed in patients with renal failure, and there will be hyperinsulinemia. But the hypoglycemia, the question was there any specific level of EGFR? In fact, even with renal failure, there is multifactorial mechanisms. Even the kidneys contribute to as much as 20% of the gluconeogenesis part. That is also hampered in renal failure. So you usually don't experience spontaneous hypoglycemia up to stage 5. So you can say arbitrarily that when the EGFR falls below 15 to 20 ml per minute, then the patient is more likely to have hypoglycemia, not in the earlier range. But if the patient is taking some secretagogue medications, then the EGFR as much as 20 to 25 ml per minute could cause a prolongation in the half-life of such drugs and can result in drug-induced hypoglycemia. So there is no established cutoff, but we usually see such episodes in stage 5 patients, especially in those undergoing hemodialysis. Okay, I hope the doubts are clear. So in this patient, we have a strong suspicion of hypoglycemic disorder, and the routine investigations are normal. The adrenal insufficiency, there is no clinical evidence of AI. Sodium potassium is normal, but I would still do a serum cortisol. If it is in the equivocal range, I would do an ACTH stimulation test. Before proceeding with the fasting test, I would do an ACTH stimulation if the serum cortisol is found to be equivocal. If cortisol basal itself is in the 2-digit level, then I would avoid doing a further synactin stimulation. Okay. Now, here we are looking at the critical sample. That is the next most important thing that we are going to learn. Many a time I've seen patients being referred from physicians who they suspect hypoglycemic disorder, and they would do a random or a fasting serum insulin. Fasting serum insulin in such patients, and because that insulin level is maybe on the higher side, they would consider the possibility of insulinoma, and straight away they would go for a CT abdomen or any morphological imaging for the pancreas. So that is such a wrong practice. There comes the concept of critical sample. So critical sample means a blood sample with glucose less than 55 milligram per deciliter. That means the sample was taken at the time of hypoglycemia. Okay, sample was taken at the time of hypoglycemia. That is what you call as critical sample. This is the most important take home message from this class. You can interpret and classify whether the hypoglycemia is insulin dependent or independent only based on a sample taken at the time of hypoglycemia. Okay, so all this insulin, C peptide, everything should be interpreted only in a patient uh, developing hypoglycemia, and the blood glucose should be collected at that time. So how can we make sure that you are able to collect blood sample at that point of hypoglycemia? That is what we call it as 72-hour fast test. So I can add some adjectives like supervised, very important. 72-hour supervised fast test. Because I've seen many patients who had come with documented episodes of hypoglycemia, low blood glucose, and they may have access to oral hypoglycemic medications or insulin from their parents or anyone else taking these medications at home. So they would do it as part of attention seeking behavior or part of certain mental illness. They may have a surreptitious use of this insulin or OHA, and they may continue to do that even during the fastest. So it is important to make sure that the fasting is always supervised, otherwise you will be falling for mistakes. Okay, this is 72-hour supervised fastest. So the principle of 72-hour fastest is to see whether the patient develops hypoglycemia or not. Hypoglycemia, because in a normal individual whose symptoms were not related to hypoglycemia would have normal reserves of glycogen and all the gluconeogenic substrates and a normal liver function. In such individuals, even for 72 hours, the body would be able to maintain the blood glucose with adequate glycogenolysis initially and later gluconeogenesis. Okay, so we want to see if the patient develops hypoglycemia within the 72-hour period during the fastest. In normal patients or normal individuals, they won't develop hypoglycemia during this 72-hour fastest. So when the patient develops hypoglycemia, you want to take the critical sample. Okay, critical sample, and that is the major purpose of doing a 72-hour fast test to first to confirm hypoglycemia, because you are doing it under supervision. You are sort of provoking hypoglycemia in a susceptible individual by asking the patient to fast. Okay, now regarding the Dr. Aravind, yeah, good evening. Yeah, Aravind is asking how to suspect hypoglycemia in sepsis. So of course, in as I told, in sepsis also it is multifactorial. So it could be due to organ dysfunction, it could be due to the increased glucose utilization within the body, and uh, suppose if a patient is having, say, a focus of infection with high blood counts, high CRP and procalcitonin, and he is developing multiple episodes of hypoglycemia, of course, you will have to look at the liver function and the renal function test first. And if there were no previous episodes prior to that, this is the first episode of hypoglycemia during a critical event like sepsis in the absence of organ failure, then you should consider the possibility of sepsis, and also you should take into consideration the possibility of uh, drugs, because many of the antibiotic drugs like the quinolones that we have discussed, the sulfonamides, all these can also result in the precipitation of hypoglycemia. There is no specific diagnostic criteria per se. It's mainly clinical. You look at the patient, rule out the reversible causes like the organ dysfunction and drugs, and if nothing is uh, like satisfying, then probably you can consider it to be due to sepsis. Okay, now coming back to our discussion, the protocol for 72-hour fastest. Okay, so you begin the testing by giving the patient a meal at 8 a.m. in the morning. 8 a.m. in the morning. So the timings could slightly change. Okay. So before starting fastest, you must have ruled out organ dysfunctions, adrenal insufficiency, any seizure disorder, because you should be very cautious. In a patient with seizure disorder, you are intending to provoke hypoglycemia, which itself is a risk factor for seizures. Okay, so you'll have to be very cautious on that regard. Okay, so meal at 8 a.m. in the morning. So what we can do is that you can start with a mixed meal test, because in one go you can identify both postprandial and fasting hypoglycemia with this 72-hour fastest. So some patient may experience postprandial as well as fasting hypoglycemia. Some patient may experience postprandial hypoglycemia only. So you can start with a giving a meal at 8 a.m. in the morning, and you check blood glucose every 30 minutes for first 4 to 5 hours. 4 to 5 hours. So this is mainly to identify such situations like the reactive hypoglycemia in a patient post-bariatric surgery in such situation, and those with accelerated gastric emptying, such situations, to ruling out that. Or there is something called as a uh, non-insulinomatous pancreatogenous hypoglycemia. I'm not going into much detail because not very important clinically for you. So in order to rule out such situations, initially I would start the procedure by giving the patient a meal, and following that I would take blood glucose samples for every 30 minutes, and I would check the blood glucose and see if it falls below the threshold of 55 milligram per deciliter. And most often in uh, long-standing hypoglycemias with fasting hypoglycemias, they will not develop hypoglycemia in the initial 3 to 4 hours. Then I would continue with fasting. Okay, continue with fasting. And how often would I check the blood glucose? The guidelines say check every 6 hours. Every 6 hours till the blood glucose is less than 60 milligram per deciliter. But in our institution, we used to check every 2 to 3 hours. So from the onset of fast test itself, we would do capillary finger stick blood glucose measurement every 2 to 3 hours. But the guidelines say every 6 hours till the blood glucose is less than 60 milligram per deciliter, and thereafter every 1 to 2 hours. So once the blood glucose is less than 60 milligram per deciliter, I'm talking about the glucometer, capillary blood glucose measurement, because it is not possible to take blood glucose via venous sample every hour or every 2 hours. That will be cumbersome for both the clinician as well as for the patient. So we will prefer the capillary blood glucose testing. Okay, and we would continue this capillary blood glucose measurement till blood glucose is less than 55 or 72 hours have elapsed. Okay, now, so when to stop, I've told you. Once the capillary blood glucose is less than 55 milligram per deciliter, if it is less than 55 milligram per deciliter, then very important, you take a venous sample. Then you take a venous sample. Okay, and this venous sample, you ask for plasma glucose, because so far we have been looking at the capillary blood glucose. I've told you the glucometer's value can go wrong at extremes of values. So you check for plasma glucose, and you confirm that that sample is a critical sample only when the plasma glucose is less than 55 milligram per deciliter. Okay, less than, only when the plasma glucose is also less than 55 milligram per deciliter, you call it as critical sample. And again, the guideline mentioned one more point. That means if the patient had a positive Whipple triad, you can stop the fastest when the blood glucose is less than 55. But if the Whipple triad is not satisfied from history, then you should continue till the blood glucose falls to less than 45 milligram per deciliter. But this is some sort of a risky game, because the patient can have significant neuroglycopenic symptoms when the blood glucose level falls below 50. So what we do in our institution is whenever the capillary blood glucose is less than 55, you collect a venous sample, and if the venous sample is also showing less than 55 milligram per deciliter value, then you consider it as critical sample, and you send for the other investigation in the same sample. Okay, I hope the protocol is clear for you. And there are certain precautions, like if the patient is having comorbid illnesses, the other drugs, if the patient uh, has a coronary artery disease, and if the patient is having angina, which could be precipitated by hypoglycemia, if the patient is having a seizure disorder, which could also be precipitated by hypoglycemia, all those things that you should keep in the mind. Now, you have got a blood glucose sample which is less than 55 milligram per deciliter. So this slide shows the entire array of investigations that you should send, that you can possibly send in hypoglycemic disorder. Because if you look at this, you can see free fatty acids, ammonia, urinary organic acid, but these are for children, especially when you are suspecting metabolic disorder. So this is the entire spectrum of samples which encompasses all the causes for hypoglycemia. Okay, all the causes for hypoglycemia, all the metabolic causes, the insulin dependent causes, independent causes, everything. But for your practical purpose, when you see an adult patient, what you focus on is insulin C peptide and the ketones. Okay, at least these things you should do: insulin C peptide and ketones. Okay, so insulin, C peptide, and serum ketones you should do in that critical blood sample. Okay. Now you have taken the critical sample and you have sent the sample for serum insulin, serum C peptide, and serum beta hydroxybutyrate. Beta hydroxybutyrate, which is the ketone body. Okay. So to tell that the patient is suffering from insulin dependent hypoglycemia, the blood glucose, as I have told, it should be less than 55 milligram per deciliter. Serum insulin, it should be more than 3 milli international units per liter. This is very, very important. To be frank, more than 3 is not very high. But in a patient with blood glucose of less than 55, your insulin should be near undetectable. So if you still have detectable insulin levels more than 3, that means your insulin is not getting suppressed and it is the most likely cause for hypoglycemia. Okay. Then serum C peptide, the levels should be more than 0.6 nanogram per ml, or if you are using nanomole per liter, it should be more than 0.2 nanomole per liter. So low blood glucose in the presence of higher insulin and higher C peptide value, you consider the possibility of insulin dependent hypoglycemia. And what happened to the ketone body in a patient with insulin excess? The ketone bodies will be negative. That means the beta hydroxybutyrate would be less than 2.7 millimole per liter. That is a cutoff that you use. So, or if you are using the urine acetone, that will be negative. So when you're doing the 72-hour fast test, one thing you can do to get a clue whether regarding this is a insulin dependent or independent cause, or if the patient is not having hyperinsulinemic disorder, is that by the second or third day of fasting, if the urine acetone is strongly positive, you can fairly rule out hyperinsulinemia, because hyperinsulinemia in such patients would strongly antagonize the ketone body generation. Whereas in a patient without hyperinsulinemia, the insulin levels will be suppressed and the patient would develop starvation ketosis. So urine acetone positive in a patient with suspected hypoglycemic disorder is a point against hyperinsulinemia. Okay, so these are the cutoff: blood glucose of less than 55, a serum insulin of more than 3 international units per liter, and a C-peptide level of more than 6 with a suppressed ketone body level. Now, look at the values in my patient. The blood glucose was 35, which is less than the cutoff of 54 or 55. Okay. And insulin definitely it is more than 3 milli international units per liter or micro international units per ml. Both are the same. So it is more than 10 times elevated above the cutoff. And look at the C peptide. The cutoff was only 0.6 nanogram per ml. It is 5.4. And anti-insulin antibody, it is a screening test that you use for Hirata syndrome, which I will be dealing later on. That is negative. So in this patient, we have clearly demonstrated insulin dependent hypoglycemia. Okay, insulin dependent hypoglycemia. Now, looking at insulin dependent hypoglycemia, we have already listed a few. One is insulinoma, then drugs like OHA and insulin. 3, we have mentioned reactive hypoglycemia. 4, we have mentioned Hirata syndrome. And 5, there is something called as nesidioblastosis or non-insulinoma pancreatogenous hypoglycemia. It's usually due to beta cell hyperplasia. Okay, so these are some of the causes for insulin dependent hypoglycemia. Now, just see the table and see in a normal individual, okay, in a normal individual, if he's undergoing prolonged fasting, then he can also have hypoglycemia. So in such patients, but he's unlikely to have prior symptoms or signs. The blood glucose would be 55. And what would happen to the insulin levels? The insulin levels will be suppressed, C-peptide levels will be low, and beta hydroxybutyrate would be high because of starvation ketosis. What happens with endogenous hyperinsulinism, as in insulinoma? The patient will have symptoms. The blood glucose will be less than 55. The insulin levels will be high. The C-peptide levels will be low, and beta hydroxybutyrate will be again low because the ketogenesis is suppressed. What happens with factitious insulin? The patient is taking insulin by himself or herself. Then the patient would develop hypoglycemia. Glucose levels will be low. Insulin levels will be high because the exogenous insulin that we have administering and the endogenous insulin have the same antigenicity, so it will be picked up by the immunoassay, both exogenous and endogenous. But look at the C-peptide level, very, very important. C-peptide level will be suppressed. So in a patient with insulin-dependent hypoglycemia as evidenced by high insulin levels but suppressed C-peptide, you think of the possibility of exogenous insulin administration. This is how you differentiate between an exogenous insulin administration and an exogenous oral sulfonylurea use. So in sulfonylurea, what does it do? It will cause an increase in both insulin and C-peptide. Okay, so factitious oral agent, it will cause a high insulin and a high C-peptide. So insulin exogenous, it will result in increased insulin and low C-peptide. Whereas sulfonylurea will cause high insulin and high C-peptide. This is how you differentiate between exogenous sulfonylurea and insulin use. Now, looking at one more cause that we have discussed, a non-islet cell tumor like a fibroma or a fibrosarcoma causing paraneoplastic hypoglycemia. They will have hypoglycemia, glucose levels are low, but the insulin levels are less. Here, the IGF-2, which is produced from the tumor, is binding to the insulin receptor to produce low blood glucose. Because the blood glucose is low, it will cause a suppression of insulin from the beta cells. Okay, so the endogenous insulin production will be low, but the IGF-2 would bind to the insulin receptor to result in hypoglycemia. Okay, now looking at the mixed meal test that we have already discussed, you'll give a meal which usually causes hypoglycemic symptoms in that patient. You would take blood samples every 30 minutes for the first 4 to 5 hours. And whenever the blood glucose level crosses the threshold of 55 milligram per deciliter, then you will send for other investigations like insulin, C-peptide, ketones, etc. Okay. Now, Once you have documented hyperinsulinemic hypoglycemia, what are the possible things that you have kept in mind? Of course, the event is postprandial. You think of reactive hypoglycemia first. Okay, reactive hypoglycemia first. Okay. Suppose what are the other situations? You have insulinoma, you have insulin, sulfonylurea, hirata. So these are the four remaining important causes. So Dr. Rose is asking, if glucometer is showing low values during fast test, can we rely on that? So that is exactly what I've told. Whenever the blood glucose through a glucometer, suppose, is showing a value of 50 milligram per deciliter, you don't take that for granted. You don't ask the patient to stop the fast. You send the blood sample in a fluoride bottle for blood glucose assessment. Okay, that blood glucose assessment will be available as early as 20 minutes. So when that report is available and that too is showing a value less than 55 milligram per deciliter, then only you will ask the patient to stop the fast. And otherwise, you will continue with the fast. Many a time I have had patients whose blood capillary glucose readings had shown 48 milligram per deciliter, but when we check the corresponding blood glucose, it was 60 milligram per deciliter. And after 1 hour, the capillary blood glucose, which was showing 48 during last hour, has risen to 65 milligram per deciliter. So that things do happen. So you do the capillary blood glucose level due to its convenience. So if the patient is willing for every 1 to 2 hour venipuncture, you can very well do that. But the sample collection and all would be very difficult. Okay, that is why we are relying on the capillary blood glucose to minimize the number of venipuncture, but not to take the blood glucometer level as the final word. Okay, I hope it is clear. Right. And Dr. Subhash has asked the difference between Dawn and Somogi. Definitely, I'll answer the question at the fag end of the discussion because it is a slight unrelated topic. I'll definitely answer that at the end of the discussion. Okay. So now we are left with these thing causes. Okay, insulin, we are not finding any difficulty in differentiating because the patient will have high insulin and low C peptide. Okay, but this insulinoma, what they will have high insulin and high C peptide. What about sulfonylurea? High insulin and high C peptide. So these two conditions can mimic each other. So that is why if you suspect the background use of sulfonylurea, which could be the culprit for hypoglycemia in such patients, you do a urine sulfonylurea screening. That is available in many centers across India. And during the episode of hypoglycemia, when you have collected the blood sample, you collect a simultaneous urine sample also. And by sending for sulfonylurea screening, you can get the important sulfonylureas like both the first generation and the second generation sulfonylureas checked out. And if it is coming back as positive, then you can be sure that this is due to a oral hypoglycemic drug use. And regarding Hirata, I'll come into that. Okay, so insulinoma and sulfonylurea, this is how you are going to differentiate between that. So suppose the sulfonylurea screening is also coming back and the screening for Hirata is also coming back as negative, you are left with a possibility of insulinoma. So how can you finalize or identify the possibility of insulinoma? By morphological imaging with CCT pancreas or MRI pancreas. MRI pancreas. And if you are having any doubt or difficulty in localization, one very specific investigation would be an endoscopic ultrasound. Especially if the tumor is located in the head and the body, then this EUS has a very high sensitivity for picking up insulinoma because insulinoma is more often a less than 1 centimeter unifocal lesion. So sometimes the morphological imaging like the CT or pancreas MRI may miss the lesion. Okay. So again, a question, what food to give during mixed meal test? So there are two options. One, you ask the history of the patient and the patient will tell that usually the episodes occur with certain food items. Like if I take idli and sambar, the patient a patient will develop hypoglycemia, or certain other foods. If the patient takes bread and jam, it develops hypoglycemia, say 3 to 4 hours. If he gives such specific history regarding a food, then you should try and emulate such scenarios by giving that same food. Okay. If there is no history of any particular precipitating food intake, then you can go for a balanced formula uh, like the Ensure, like the pre-mixed protein and nutrient formulas like the Ensure or the Sustacal. So many brands are available in market, and the dosage is actually weight based. Okay, I can discuss that in the group as well. It is actually weight based dosing that you give if you are using a nutrient powder like Ensure. Otherwise, you can ask the patient to take the food that most often result in hypoglycemic symptoms in that individual. Okay. So coming back to our imaging localization, you can do a CT, MRI, endoscopic ultrasound, and if still there is room for doubt, you can go for a functional scan. Okay, functional scan, which is the preferred one, is the extended PET scan. Extended PET scan. Gallium 68 extended PET scan. I'm not going into much of the details. The extendin will bind to the GLP-1 receptor. The GLP-1 receptor will be abundantly expressed in the insulinoma, whereas it will not be there in other pancreatic neuroendocrine tumors. So by doing this extendin PET scan, you can differentiate insulinoma from other pancreatic neuroendocrine tumors. The other one would be gallium 68 dotatate PET, DOTA-PET. The problem with DOTA-PET is that DOTA-PET can be positive in a non-functioning pancreatic neuroendocrine tumor also. Okay, so the extendin scores higher than the DOTA-PET in specifically identifying the insulinoma lesions from the pancreatic tumors. Okay, so our patient, when he was subjected to CT abdomen, there was a rounded lesion with significant arterial enhancement. So this very high arterial enhancement is actually specific for pancreatic neuroendocrine tumor. So medial to the neck of pancreas, we have identified a 1.2 into 1.5 centimeter lesion, and we again proceeded with the extended PET scan. Here in extended PET scan, you could identify the lesion. See, that lesion has lit up like a bulb. So this is how a positive insulinoma lesion would show up in an DOTA extended PET scan with a very high uptake of 55 standardized uptake value, 55 SUV max. And this is suggestive of the abundant GLP-1 receptor, suggestive of insulin. So final diagnosis in our patient, spontaneous hypoglycemia with endogenous hyperinsulinism caused by a functioning pancreatic neuroendocrine tumor, insulinoma, as confirmed by the extended PET scan. So how did I manage this patient? Because I've identified a definite lesion here, the surgery was enucleation of the tumor. Okay, enucleation of the tumor was done, and the patient developed spontaneous resolution once the tumor was completely removed. And if it is not surgically compatible or metastatic insulinoma, then we can use a particular drug that reduces the insulin release from the tumor cells, which is diazoxide. Okay, diazoxide. Again, the dosing and on, I'm not going into the details because you can, if this itself is a rare situation, if you are getting such a situation where that demands diazoxide, then you can definitely read up, or you can message me in WhatsApp regarding the dosage of diazoxide, how to monitor a patient who is started on diazoxide and all. Okay, right. So with this, we have come to an end of the insulinoma discussion. We have started all the way from the history, examination, biochemical examination, the fast test, how we are interpreting that, the normal values, the abnormal values, and finally to the imaging and management. Now we are looking at one more different or distinct case of hypoglycemia. The patient is a 70-year-old female, so is an elderly female, non-case of coronary artery disease on clopidogrel, atorvastatin, okay, for 5 years. Now she is developing recurrent episodes of hypoglycemia for 2 months. So she was apparently normal for the last so many years having a new onset recurrent episodes of hypoglycemia, and the lowest recorded GRBS was 27 milligram per deciliter, and Whipple's triad was positive. Whipple's triad was positive. So when the Whipple's triad is positive, you have a high likelihood of the patient having a hypoglycemic disorder. So this patient developed hypoglycemia during the 72-hour fast test as early as third hour. So you can say it is sort of a postprandial hypoglycemia, but even severe cases of insulinoma can also present with postprandial hypoglycemia. Okay, so critical sample at 3 hours had shown the RBS from the plasma has shown 45 milligram per deciliter, but look at the serum insulin. This is 1200 and serum peptide is 10 nanograms per ml. You have seen a previous patient with insulinoma where the insulin levels was around 30 international units per liter. Okay. Here you have seen insulin levels in 4-digit figures more than 1000. So when you see such high insulin levels more than 1000, two conditions you should suspect. One, exogenous insulin therapy. But what will happen to C peptide in exogenous insulin therapy? It would be suppressed. But here there is very high levels of insulin with a positive or a detectable C peptide. So here you should think of the possibility of a condition called as Hirata syndrome. Okay, Hirata syndrome or insulin autoantibody or autoimmune syndrome. Insulin autoimmune syndrome or insulin autoantibody syndrome. So in Hirata, what is happening is that I'll show you. The classical abnormality is the anti-insulin antibody. Okay, the patient develops anti-insulin antibody. But you may think that if the patient is having anti-insulin antibody, the patient should develop hyperglycemia, not hypoglycemia, right? But this anti-insulin antibody has got two uh, peculiarities. It has got a high binding capacity to insulin, but low affinity. So what happens is that when the patient takes a meal, there is a surge in insulin production or insulin release, and all these antibodies will go and bind to the insulin. So that insulin is not able to act on the receptor. So what happened? There is reduced insulin action and hyperglycemia. Okay, so there is hyperglycemia initially. But what happens? This antibody has a low affinity for insulin. So it cannot hold on to the insulin for a long period of time. So what happens after a particular period of time, say after 2 to 3 hours, all these insulin that has been sequestered by this antibody will be released at once. So instead of a controlled release of insulin from the pancreas, all the insulin molecules which was previously binding to the insulin was released at once, and it binds to the receptor to result in hypoglycemia. So this is the basis of hypoglycemia in a patient with Hirata syndrome. So the culprit is the anti-insulin antibody, which has a high binding capacity. That means it can bind to a whole number of insulin molecules with low affinity. Low affinity is the result, is the cause for the release of insulin in the late postprandial period. Okay. So the patient, the serum insulin is 1200 and the insulin antibody was also very high, more than 300, confirming the diagnosis of Hirata. So polyethylene glycol precipitation is one diagnostic test that we use to confirm the Hirata. So why the serum insulin is in thousands in this patient? It is because the insulin is bound to antibody, and this is being detected by the assay. When you add polyethylene glycol, the antibody will be precipitated. Okay, the details you don't need at this level. You just know that polyethylene glycol precipitation is done to confirm Hirata syndrome, and you can also do an serum insulin antibody to confirm the diagnosis of Hirata syndrome. Right. So why does Hirata occur? The two major causes include drugs, autoimmune conditions, and malignancies. Malignancies like myeloma. So in our patient, the clopidogrel is one of the culprit which has been listed as one of the causes for Hirata syndrome, and we replaced clopidogrel with aspirin. And to reduce the autoantibody concentration, we have started the patient on prednisolone, and at 2 months of follow-up, the patient had no hypoglycemia whatsoever. So this is how you approach a patient with Hirata syndrome. Here, Hirata is more common in Asian people due to certain genetic predisposition, and the patient would have hyperinsulinemic hypoglycemia with elevated anti-insulin antibodies. So the diagnostic criteria is very high levels of insulin. The ratio of insulin to C-peptide is usually more than 1. Why is the ratio more than 1? Because it is only the insulin that is sequestered in the antibody and not the C-peptide. So the levels of insulin will always be higher than C-peptide in a patient with Hirata syndrome. Whereas what happens in insulinoma, even though the insulin and C-peptide are produced in the ratio 1:1 in insulinoma, the half-life of insulin is only 5 minutes, whereas C-peptide half-life is 30 to 60 minutes. So at a single point of time, when you look at both the concentration, the C-peptide concentration would be higher than that of insulin. So the molar ratio of C-peptide would be higher than insulin in a patient with insulinoma because of long half-life of C-peptide, despite both being secreted at equimolar concentration. Right. So, which are the important drugs that can precipitate Hirata? 3 important drugs you should keep in mind: methimazole, alpha lipoic acid, and clopidogrel. So, methimazole, as you know, is the anti-thyroid drug. So, methimazole, alpha lipoic acid, and clopidogrel are the most common drugs associated with insulin autoantibody syndrome. So the difference between insulinoma and Hirata, the timing of hypoglycemia, Hirata it's mostly postprandial. The discussion we have already seen. It is associated with autoimmune conditions, multiple myeloma, etc. Associated with drugs. Then insulin C-peptide ratio more than 1. The serum insulin usually more than 1,000. And the treatment, once you identify the precipitating cause, withdrawal of the cause would result in the resolution. And sometimes you will have to use immunosuppressants, steroids and steroid-sparing immunosuppressants. So finally, the case scenarios in hypoglycemia. Hypoglycemia in a patient with weight loss, hyperpigmentation, and hypertension due to, because I've already overshooted the time, so I'm just discussing the answers straight away. The diagnosis is adrenal insufficiency. Recurrent hypoglycemia in a patient post-bariatric surgery. In a patient who has underwent the gut resection as part of bariatric surgery, they will have increased GLP-1 levels. So increased GLP-1 levels would result in increased insulin. So this is what you call as post-bariatric surgery hypoglycemia. Post-bariatric surgery hypoglycemia, it is something of a sort of a reactive hypoglycemia that occurs due to elevated GLP-1 levels. So hypoglycemia in a patient with pituitary adenoma and hypercalcemia is likely MEN1 with insulinoma. Hypoglycemia in a patient on methimazole for Graves' disease. You have seen methimazole is an important culprit that can result in Hirata syndrome. So in such patients, you will always entertain the possibility of Hirata syndrome. Hypoglycemia in obese pre-diabetic patient in postprandial period, you should think of reactive hypoglycemia. Okay, so I think we have come to the end of our discussion. So just think that all patients who present with symptoms likely to be hypoglycemia need not be hypoglycemia in all cases. Okay, that is very, very important. And the clinical suspicion of hypoglycemia should be considered high if the Whipple's triad is satisfied. Okay, otherwise you should always take those history with a pinch of salt. And very, very important, never interpret serum insulin and C-peptide in a non-hypoglycemic blood sample, except sometimes in Hirata. In Hirata, even without hypoglycemia, the patient may have insulin levels more than 1,000. So that may give you a clue. Even one patient with history of hypoglycemia, but currently not hypoglycemic, he may still have insulin level more than 1000 in Hirata. So cutoffs for insulin-dependent hypoglycemia, the insulin and C-peptide cutoff we have learned. Then how do you work up for insulinoma right from the basic investigations to your fastest, interpreting the insulin and C-peptide levels, and finally going on with the imaging. And Hirata syndrome, when to suspect and how to manage, especially when you get serum insulin more than 1000 or three-digit levels, you should think of Hirata syndrome, and you should always look for the culprit drugs, autoimmune conditions, and malignancies. Okay, so I think that's it from the discussion. Any questions you can type in the chat box. I'll be happy to answer. And if insulin levels show a value within normal range during hypoglycemia, insulin level, I can tell you that in a normal individual, fasting insulin can be as high as 20 milli-international units per liter. So if you take the cutoff for hyperinsulinemic hypoglycemia of 3, it is actually low. But you expect the insulin levels to be even lower or undetectable in a situation of hypoglycemia. So either normal or high insulin levels in the setting of hypoglycemia is considered significant. That means hyperinsulinemic hyperglycemia can be diagnosed in a patient with unsuppressed insulin levels during hypoglycemia. Unsuppressed means either normal or high. Okay. And one of the questions that I've got regarding Dawn and Somogyi phenomenon, that is regarding the insulin treatment in a patient with diabetes. Both the Dawn phenomenon and Somogyi phenomenon patients will present with high fasting blood glucose. So if the cause for high fasting blood glucose is the counter-regulatory surge, especially the growth hormone surge occurring during 3 a.m. or 3:30 a.m. is what we call as Dawn phenomenon. So Dawn phenomenon is due to the reduced availability of insulin to counteract the counter-regulatory hormone surge occurring in early morning. So in such patients, should be treated with higher doses of basal insulin. Somogyi phenomenon means the patient, due to the excessive administration of basal insulin at night, especially the basal insulin with a peak like NPH insulin, that would trigger a hypoglycemia at around 2 a.m. or 3 a.m. And due to the episode of hypoglycemia, then there will be a counter-regulatory hormone surge resulting in hyperglycemia in the morning, 5 or 6 a.m. So both Somogyi and Dawn phenomenon would present with fasting hyperglycemia, and by looking at 3 a.m. blood glucose, if it is low, then the diagnosis is Somogyi. If it is normal or high, it is Dawn phenomenon. So treating Dawn phenomenon, you have to increase the basal insulin dose, and for treating Somogyi, you have to decrease the basal insulin dose. So I think that's it. I hope you have found this session useful, even though I've taken it a bit more exhaustively to cover all the important points. I strongly believe that it would be of great practical use for you while approaching a next patient who is suspected to be having hypoglycemic disorder. So if there are no further doubts, I think I'll wait for 30 more seconds and then I'll sign off. So I can see no more questions coming up in the chat box. So thank you very much for joining in. And this is my WhatsApp number. In case of any doubts regarding whatever I have taught or regarding your cases that have to be discussed or regarding the entrance preparation, you can WhatsApp me in this number. And any doubts from this session also, you can really clarify by texting me. Okay. So thank you all. So good night. I hope you all have a good